We've assembled a great panel for you, which kind of reflects the patient journey from the GP through to the oncologists and the nurse. So without further ado, I would like to hand over to Dr. Mathew Thomas, who is the cancer GP in East Sussex. He has collaborated with Dr. Alex Manson-Barrett. Can't be with us, has a family bereavement, which is taking elsewhere. So he will be followed by Dr. Richard Simcock, Brighton and Sussex University Hospital Trust, who's a Macmillan consultant partner. And also, to bring up the rear is Scarlett Jinman-Dunt, formerly an oncology nurse, now information support service and Macmillan Horizon Centre. Right. So I'd like to hand over now to Dr. Mathew Thomas, and I will say before he gets going, the presentation you're going to see from our three panelists will be available on all health websites, and a recording of this event will also be available. And my colleague will be creating a summary of the key points, which will be circulated to everyone who's registered and put up on the websites as well. So over to you, Mathew.
Thank you, Geoffrey. The next slide, please. Next slide, please. So thank you very much for joining us today. As you know, I'm a GP, and at the moment, we are all aware that cancer is a priority, and it's a real priority. So we know that 50% of us will have cancer, a cancer diagnosis during our lifetimes. Most of them are treatable. So 50% of patients survive 10 years from diagnosis, and those figures are taken from 2010. So we know they are much better than that. And in some cases, like breast, it's 75%. And again, that data is quite old. It's better than that. And prostate cancer is 78%. So coming forward early and being diagnosed early and being treated early is what we need to be doing. GPs have a role in prevention, screening, early diagnosis, and living well with and beyond cancer. And these are the people that you actually know in the community. Next slide, please. So just to give you a little bit of background, there is something called the 2-week wait rule, which you may have heard of. It was brought in 2005, and the NHS agreed criteria for urgent referrals for cancer, essentially to improve the diagnosis and make sure patients are seen early and treated early, and to reduce missed cancers. It's based on the recognition of certain symptoms and signs. So symptoms are what you tell us, and signs are what we find when we examine you. And these are associated with in those days, it was a 5% risk of having cancer. So if we thought that you had the symptoms or signs, we would then refer you for urgent assessment and investigation. There's a target set, and that's what the 2 weeks is about. So the target is that the patient leaves the referral leaves our building within 24 hours of you talking to us, and the first appointment with a secondary care specialist is within 2 weeks, and hence 2-week wait. And there is also a treatment target, so that the time from leaving us to having your first treatment, should you get cancer or be diagnosed rather with cancer, is 62 days. So this is subsequently refined in 2015, and the threshold, so we had 5% before, so the threshold dropped to 3%. So that's a 3% risk of having cancer based on what you tell us and what we find when we examine you. So now the aim is to diagnose or indeed to exclude cancer for those who don't have it within 28 days from the first referral by the GP. Next slide, please. So how things change in 2020 because of COVID-19? Actually, the 2-week wait pathways are still open. So we all know what's happened. but I want to reassure you that the pathways are still there and they're still open. So we and the hospital want you to come to us and to report any worrying symptoms. And we don't want you to sit on things because that won't help you or the health service to treat you. The first contact you may have noticed with your GP is by telephone these days, or a video link. And then there might actually be face-to-face contact, depending on whether that's required for an examination. And we do that in what we call a COVID protected place. So we've organised ourselves so that there is as low a chance of being exposed to COVID-19 as possible. We've got new technologies in place to try and aid all of this. So there's an app that goes with smartphones that looks at skin lesions, for example. So these are all new things that we've rapidly put in place. We've also got to think about the risk of cancer versus catching COVID-19. I know that's a worry for everyone. And GPs will have their own experience of what's going on locally and of looking at you and understanding what your needs and what's going on in the background for you in terms of your age and other illnesses. So all of that has to happen now. Next slide, please. Next slide, please. So what happens after we refer you? Well, again, first contact is likely to be by a phone or a video link from the hospital. And then they decide with you what subsequent investigations will occur. And some of these have had to be adjusted, partly because it's risky for you and partly because it's risky for the staff. So things like endoscopies have had to be changed, and we call it risk stratification. So it's to get people dealt with urgently first, and with as little risk to them and the clinicians doing the investigation as possible. It's undertaken, a lot of it's undertaken in low-risk sites away from the main hospital units. And so again, that's to make it a sort of COVID, what we call a COVID protected environment. And if we decide to refer for possible cancer, it's important to accept and keep those appointments. I know it's really tempting to say, well, I want to bring my problem to my GP, but I'm really not sure about going on to have an endoscopy or have a CT scan or have anything else done. But actually, we're doing everything we can to make the space safer or as safe as possible for you. So it's really important to engage if we actually do refer you. And I wanted to just reassure everyone that if you feel that you're in the system, that something's happened and you don't quite know what's going to happen now, whether you'll be delayed, the hospitals are holding a list, and they look at that list very regularly to make sure that people are prioritised and that they are kept an eye on. So you're not missed out, you're not lost. Next slide, please. In terms of screening, because we all look at screening as well, the cervical screening, as you know, there are three national screening projects generally. The cervical screening is initially being risk stratified. Letters are now being sent, so we are starting to ask people to come in for them, but please wait for your letter or wait for your practice to call you. In terms of bowel and breast, they've both been paused, partly so that the backlog can be cleared of those who are testing positive in the bowel situation, and then for breast, then you know that obviously a lot of the breast is done in vans which have to be cleaned. So those issues are currently being worked through, but that is hopefully likely to be started soon. Next slide, please. So I thought I'd give you a couple of examples very quickly of the sort of thing you might expect. So we've got here a 72-year-old Asian lady with poorly controlled type 2 diabetes and a body mass index of more than 30, who's noticed that she's got loose stools. That's the thing that's brought her to us for a few weeks. And the first thing that will happen is that she is likely to call her GP practice, who who will say, yep, we'll take your details and the doctor will call you back later today. The doctor will indeed call back, and he will discuss symptoms and the plan of investigation with her. He will possibly request her to attend in person in the green, in inverted commas, part of the surgery, the protected part, because he might need to examine her abdominally. And at that examination, both the GP and, as of now, the patient is being asked to wear a mask. GP obviously wears more protective equipment than that, so gloves and a pinny. The GP will check all of the contact details and then we'll make an electronic referral and give the patient a letter to explain what this is all about, with a contact number on it, should there be any delays. The patient in this situation, because it's loose stools and because it's a concern about the bowels, may well be given a stool sample test to look for blood. That's quite important. That's a new thing. It's been introduced to try and help stratify the people we need to look at first. And then there's the all-important thing, the concern about risk. So people have asked this quite a lot. What are my risks if I go to hospital? Well, there are various calculators around, and GPs will use your gender, your ethnicity, your age, your illnesses, and that's why I put all of that in this example, to work out what are the risks for you personally. And then, of course, have you been asked to shield at home? So having looked at all that, and if you're worried, he will discuss that with you. And he will discuss the issues around risk and around the risk of the cancer itself. And then you can decide that this is the right time for you to be sent to hospital. And for the vast majority of people, it is the right time to be referred. You will then be phoned by the hospital probably within 3 to 4 working days by one of the hospital clerks to book you into a slot for a telephone consultation, and that will be had with the consultant. And then in this case, the likelihood is the patient will be asked to attend for some sort of examination, either a CT or a colonoscopy. And again, they would ask you to isolate for 14 days prior to the procedure. So I think you'll get the impression that we're doing everything we can to make the risk as low as possible for you should you go to hospital. And when you arrive at hospital, obviously you're going to be wearing a mask, everyone's going to be wearing protective equipment. So again, everything is being done to protect you. Next slide, please. So I'm just going to run through this very quickly. So this is a 55-year-old white man with high blood pressure and a BMI, body mass index of over 30, noticing a new mole that's changed in size and shape in the past few months and is itchy. So again, the gentleman would call the practice, be called back by one of the GPs, but in this case, the new piece of technology would come into play. So we would either use a new app that the patient would download on their mobile phone, and they would be able to take a photograph of their mole and send that to the hospital directly if it's through that app, or on their mobile phone to the GP practice, who would then decide whether that needs to be sent on. So the GP, with moles, it's obviously sensible to look at them, and that's why this new piece of technology will be used. The likelihood is that the referral will go ahead in the way we've just discussed with the lady, and the GP may well ask either that lady or this gentleman to have a blood test at the same time as that referral goes, and this would be done as an urgent case. So that there's enough information for the hospital to make better decisions at their end. Again, they'll have that discussion about risk. In this case, actually, it's overwhelmingly sensible for him to be referred to hospital, because this could well be a melanoma, so a skin cancer. So it's worth being referred. And again, the same applies. Telephone call from the hospital, they will review those photographs, and if they think it's something that needs to be removed, and looked at under a microscope, they will obviously organise that. And again, some of those investigations are done in what we are calling a COVID protected environment. So there are various units around the area where that is the case. Next slide, please. So these are often the problems that we've come across. It's about who you contacted. Things aren't going well. So if your symptoms have changed or have worsened, then if you've been referred, then there are usually telephone numbers on the referral letter, and there is also a hospital telephone number that can be called to let them know that your symptoms have worsened. However, you can also go back to your GP and say, I haven't heard anything, my symptoms are getting worse. If there's a delay in your first hospital appointment, again, there's a telephone number at the bottom of that patient letter that you got when you were referred by your GP. In terms of a delay in your first or subsequent investigations in hospital, then again, it's the hospital that would be the sensible place to call. And both Brighton and Esht, that's East Sussex Hospital Trust, Eastbourne on the Conquest, have dedicated numbers that you can call, and you will be given those numbers. If there's a delay in your first or subsequent treatment, again, it's the hospital that you would need to call, and they are set up for this. This has been thought through, and they are available to talk to you. It may not be instantly. You may have to put your name on an answer machine, but they will call you back very quickly. Treatment side effects, again, that's the hospital. And then worrying hospital letters, well, to be honest, as a GP, patients get hospital letters and they do get worried. And the person they know and they want to ask an opinion of is often their GP. GPs won't mind if you do that. But again, the numbers we've talked about are there. And the hospital is also happy to take those calls. Thank you. Next slide, please.
Okay, before I introduced Dr. Richard Simcock, I should have mentioned in my introduction that we've had a lot of questions in advance, and I see one or two coming in. If you have questions as each presentation progresses, pop them into the chat panel, and we will try and deal with all the questions if they haven't been actually answered during the presentations. And in our allotted hour, if we run out of time, we will endeavour to answer every single question that comes in that hasn't actually been dealt with in the presentations. So if I can now ask our oncologist, Richard Simcock, to take on the presentation to the next stage.
Thank you, and thanks for the opportunity to discuss this with everyone. I can have my first slide. Geoffrey talked about lived experience of this, and I thought I'd just start with my own lived experience of Sussex has a little bit of notoriety in the COVID story because the first patient, non-Chinese patient to get COVID in the UK was infamous super spreader Steve, who contracted COVID virus in Malaysia, in Singapore, and then came to this ski chalet on the right. He was on a ski trip with 6 of my best friends, and it was only by dint of a rotor mishap that I wasn't on the same ski trip, unfortunately. And one of the people in that ski trip then returned to England and stayed in my house for a week. So my first experience of COVID was to be put in quarantine for 2 weeks, whilst people in hazmat suits came to collect the infected person from my house and take them off to St Thomas's Hospital to be isolated for 2 weeks. And at that time, there were 8 infected people in the UK, and 6 of them were close friends of mine. So I was in close contact with all of them. And I should say, with some sympathy with the politicians, that despite the fact that being at the very heart of it during those 2 weeks, even I back then never dreamt that we would be where we are right now. So I have some small amount of sympathy for the politicians who didn't get to it quickly enough, because despite being very intimately involved with the very first steps of COVID in this country, neither did I. But anyway, there we go. Next slide, please. So as we started to understand that COVID was going to be a problem towards the end of February and early March, we started to gather in our individual departments and try to understand what the impacts were going to be. And that required some capacity and demand planning and some disaster planning, which relied on some metrics which we simply didn't have. We had our knowns, we knew what the expected cancer caseload was going to be, and we understood what our current operational capacity was. We already knew we had workforce shortages, and we already knew we had the longest cancer waiting times list that we'd had for some good many years prior to Christmas. What we didn't know was what the infection rate was going to be, the now infamous R rate. We didn't understand risk stratification. We didn't understand what COVID was going to do to the risk of having a cancer treatment. And I'll explain a little bit more about that at a moment. And we didn't know what it was going to do to our own staffing levels. We didn't know how many of our own staff were going to be off and how we were going to be able to run units if we had a 5%, 10%, 20%, 40% sickness rate. And then, to quote Donald Rumsfeld, pictured here, there were unknown unknowns. We had no idea what the PPE supply was going to be, and at that stage, no one was really talking about testing capacity or how that was going to be ramped up or how testing policies were going to be introduced. So, our initial disaster planning, capability planning, was based on a number of known metrics, but a huge number of unknown metrics. And I think that goes some way to explaining why these systems are in constant flex. And in our own department, in the Cancer Centre, we have 2 calls a week, Monday and Friday, where we gather intelligence and say, how does the land lie this week? And how do we need to change our services for next week? Next slide, please. So the one piece of data we had early in the piece was this data from Wuhan, which was terrifying. It was a small amount of data looking at the outcomes of patients with COVID and looking at how that translated in terms of comorbidities. And what we were particularly interested in is how did patients who had cancer or patients who previously had cancer fare if they had had COVID. Now, if you look at the bar chart on the left, you'll see patients, all of these patients who had either invasive ventilation in pink or may have died. Blue patients had a clinical indication for invasive, so may not have actually been ventilated, but may have been indicated. You'll see that patients who had no cancer from the Wuhan group, if we look at just the blue bars, about 15% indication for ventilation or ventilation and death. If a prior history of cancer led to a rate of about 40%, and patients who currently had cancer, 75% of those patients were either dying of COVID or requiring ventilation. And that was an absolutely terrifying figure for us, and it informed a lot of what we did next in terms of planning how we would move forward with chemotherapy treatment. So if I have my next slide, please. When we give treatments, every treatment that we offer to a patient should be based on a risk-benefit discussion which is individualized to that patient. And in common practice, in evidence-based medicine, we will have a clear idea of what the benefits are. And those benefits are known to us through clinical trials, from practical experience, and from our own data. We also understand what the risks are in our normal situation, but what COVID had done has suddenly put a big question mark over risk. We suddenly didn't know what the risks of chemotherapy might be. So in my practice as a breast cancer oncologist, if I treat a woman with adjuvant breast cancer chemotherapy, I will consent that patient that she has about a 1 in 8 chance of requiring hospital admission for antibiotics during therapy. She has about a 1 in 200 chance of needing those antibiotics on an intensive care unit. And she has about a 1 in 1,000 chance of dying despite antibiotics and intensive care of infection. Now, that is a very low risk. It's a risk we're hugely attentive to, and we are able to mitigate most of that risk and treat patients safely. We were looking at a situation where a treatment that might have a benefit of 3 or 4% absolute survival advantage might be more than doubly outweighed by a risk of mortality during COVID. And that informed a lot of the discussions that happened early on in the piece about us reducing the amount of chemotherapy we were giving, reducing the amount of radiotherapy we were doing, and reducing the amount of surgery we were doing, because we were extremely concerned that the risks of those procedures during COVID might greatly outweigh any benefits. At the same time, we deliver chemotherapy exceptionally safely, because if a patient is unwell with a fever, they ring our unit up, They're triaged immediately to A&E. They get a blood test done within an hour and antibiotics within an hour. And we were expecting a scenario where that A&E service was totally overwhelmed by COVID and that those support and safety netting systems may not be in place. We also knew that surgery may not be able to take place because of a demand on ventilators to ventilate patients with COVID, so it simply wasn't possible to anaesthetise patients or manage them in HDU. And we knew that the radiology services that we use to stage and assess our treatment were not going to be available because they were redeployed. We also knew our own staff were going to be redeployed, and indeed I spent 2 weeks myself as a care of the elderly consultant on COVID wards where I wasn't seeing my own cancer patients. So that was the initial aspect. We could just move on. I have to say the situation has improved, and what we now have, which we didn't have 2 months ago, is better data. And the data I've got on the screen for you here is from the UK Cancer COVID Monitoring Project. This is a voluntary reporting project which all the oncologists in Sussex are signed up for. And any patient who has a diagnosis of cancer at any stage and also has a proven diagnosis of COVID, we are asked to submit their clinical data and outcomes to a database which is held by the University of Birmingham. And the University of Birmingham have now collected 1,300 cases. The first 900 cases were reported in the Lancet 2 weeks ago. And what that data shows us is that cancer in this much larger data set than the data set we saw from China, cancer does not seem to be a significant predictor of poor outcome from COVID. The bar charts on the left show you outcomes from COVID, and red is patients who've died of their COVID infection, and purple is patients who are discharged home. The bar on the left is people who've had chemotherapy within the previous 4 weeks, nearly just over 400 of those patients. And the remainder are patients who did not have chemotherapy in the previous 4 weeks. Now, our expectation and our bias was that patients on chemotherapy, if they got COVID, we would have expected them to do badly with COVID, and we might have expected them to have a higher mortality. That has not been the experience from these first 1,300 patients in the UK, nor, must I say, has it been the experience of the first 900 patients that have also been now published from the USA. You can see that a COVID diagnosis did prompt clinicians to change the cancer plan. So the graph on the left shows whether or not the COVID plan, the treatment plan was interrupted because of COVID. Over 59% that wasn't the case, but in 40% of cases, if the patient got COVID, it was felt necessary to change their treatment plan, and there may be long-term implications of that. So I think we can draw two conclusions from that. The best thing we can do for our cancer patients is make sure they don't get COVID in the first place. But the second thing we can be more reassured about is that getting COVID during cancer chemotherapy is a bad thing, but it's certainly not as bad as we first anticipated. And in that context, I think the new guidance around shielding that was badly announced, the announcement was badly managed, mismanaged, but actually I think the announcement itself was correct. And what I'm seeing in my clinic is a large number of patients now who are experiencing enormous emotional and psychological distress from the impact of shielding. And I'm very pleased to see those shielding restrictions very slightly lifted, and I think that's a safe thing to do in the context of this data. And I don't think that the messaging has gone out that I think that shielding restriction lifting is consistent with the data. Next slide, please. So what are we doing now? And I say this is a fluid situation. Well, first of all, our outpatient practice has changed enormously. 90% of my consultations now are either by video chat. We're using the NHS Attend Anywhere platform. I've just been piloting that with 3 other oncologists over the last week. I have to say video is a huge leap forward over telephone. We are enormously grateful to the Macmillan Horizon Centre, who have donated their space to us to use for clinic capacity. That in turn has allowed us to turn the outpatient service in the Sussex Cancer Centre to the haematology day unit, and that in turn has allowed us to turn the haematology day unit into acute oncology unit, so that patients with acute cancer problems can be seen outside of the A&E space by dedicated oncology professionals. And through a change in rota, that now has 24/7. That we now have 24/7 acute oncology consultant-led advice, and from 9 in the morning till 9 at night, there's a consultant presence. We are managing to maintain our outpatient activity at normal levels for follow-ups, and we are doing face-to-face when it's necessary. I'm sat in Eastbourne Outpatients just now, where I've done a clinic, and all of the new patients I've seen today, I've seen with appropriate PPE, and the patients have been wearing a mask as well if necessary. So outpatient services are running well. Diagnostic services are now getting back up to speed. We had a massive backlog of scans. With the help of our radiology colleagues, we've been able to go through that scanning list and decide scans that, with the time been and gone, do we still need them, and do we still need to do them? And some scans we've agreed that we can do without and make assessments in other ways. And we are now starting to claw back the shortfall. And I think one of the unsung heroes for me in the hospital are the radiologists, who worked exceptionally hard to scan all the COVID patients, and they've not been able to take their foot off the gas for 1 second, because now we're hammering them with cancer workload. Surgery had a slow start, but surgery has now been decanted in the main to clean surgical hubs. So cancer units where we can deliver cancer surgery down a green, non-COVID pathway, where patients are screened prior to treatment, isolated prior to surgery, and we can give their cancer surgery away from the main hospital. So doing gynecological and colorectal surgery and breast surgery at the Montefiore Private Hospital at Hove, some head and neck and breast surgery going on at Queen Victoria Hospital East Grinstead, and flexing the private capacity that the NHS has bought sensibly. I don't think we're not anywhere up to speed yet. Getting those patients through that pathway is much slower, but we are starting to claw that back. Chemotherapy, well, for reasons I explained, we gave a lot less chemotherapy. That seemed the right thing to do at the time. We're now going back to pre-COVID levels of activity, but delivering that in a cautious and careful way. We have made some cautious adjustments to protocol. And radiotherapy, likewise, we've adopted some what we call hypofractionated policies. So breast radiotherapy that previously was given over 15 sessions, we now know can be safely given over 5 sessions. And just today, the NHS England gave us a small SOP in saying that we might now be able to commission stereotactic radiosurgery, which is a good and safe alternative to lung cancer surgery and some other cancer surgeries. So starting to claw back normal activity in all areas, and also doing some modified activity in a COVID time. Next and last slide, please. So where do we go from here? Well, we are now adapting to a new normal, and that picture on the right is Liz, one of our therapy radiographers. And if you come to our department now, that's what you'll be greeted by, healthcare workers in gloves, apron and masks. You will be symptom screened for COVID at every visit. Have you had a fever? Have you been living with anyone with a fever? And you'll be tested for COVID prior to starting a new course of therapy. That way we hope to keep our departments clean of COVID, so that we don't we have red pathways in place, so that if a patient became infected, or we found out a patient was infected with COVID whilst treatment on our machine, we've got isolation and streamlined pathways so we can carry on business as usual and maintain the pathways without disrupting. The next phase in our planning, and the thing that's occupying now, is how do we begin to start to plan for the surge that is undoubtedly coming. In the last few weeks, the number of new patients I've seen in my clinic has been half what I would normally expect. The cancer wait times data for March saw 26,000 fewer patients seen in hospital based on referrals by their GP with suspected cancer, and we can only expect that to contain a large number of undiagnosed cancers which will be coming our way, I hope sooner rather than later. So the next phase is to plan to accommodate those. Thank you very much.
Okay, thank you so much, Richard. We move on to our final presentation, and thank you everyone who's been posting questions in the chat screen. I've clocked all of them, and we've got some that we had submitted in advance. And Scarlett Jinman-Dunt, whose lovely picture you see now on your screen, has finished her presentation. We will start dealing with those questions. Thank you, Heather. Angela, rather, who's just put in another question. So over to you, Scarlett. I've taken up some of your time already.
That's all right. Hi, everyone. My name's Scarlett, and I'm just going to be quickly going through some of the services that Macmillan are currently offering in the area and also nationwide. Next slide, please. So I'll mainly be focusing on the Horizon Centre in Brighton, but information centres across the area, such as the Olive Tree, the Fountain Centre and the Centre at Queen Victoria, are also offering similar support, as are Age Concern in both East and West Sussex. I've sent Michelle the East and West Sussex Macmillan leaflets, which have more information, and they are available on the Health Watch website. All the information I talk about regarding our services can also be found on our website. So since going into lockdown and handing the centre over to the Trust, we've tried to move as many of our services as possible to either phone or virtual sessions. One of the first services that we moved across to phone support was the counselling services. So all these appointments are now over the phone for both existing and new clients. The service is still taking referrals, and Kath, who runs the service, is still doing assessments of new clients. Today, we also ran our first mindful half-hour session, which runs once a week to replace the mindful half hour that we used to run in the centre. We've also moved all our welfare benefit services across to the phone. Again, this service is still taking new referrals, whether that's self-referrals from clients themselves or referrals from healthcare professionals. I really want to raise awareness about these services and the fact that they are still running, because we have seen a decrease in the number of people accessing welfare benefits. Also, citizens' advice in both West and East Sussex are still open and running. We've also started introducing some information and support phone calls. We have a group of 4 experienced information and support volunteers who have been matched with clients, and they phone them as often as they like. These volunteers offer information and support advice that's relevant to the client's need. We are hoping that this service will help to bridge the gap for people who would usually come into the centre and speak to one of our volunteers in person. We've started running a number of virtual support using Microsoft Teams. One of the first sessions we started running is a session called Horizon Connect, which we run on a Monday, Wednesday and Friday. This is a virtual group session in which people can talk to others who are in a similar position to themselves. They can share how they're feeling, provide peer support and practical hints and tips, whether that's regarding lockdown, diagnosis or treatment. It's not a structured session, and it's open to anyone, no matter their diagnosis or current treatment. It's also open to relatives and loved ones of people who have a cancer diagnosis. We've also started running some managing anxiety sessions on a Thursday, and these sessions cover how to prevent anxiety building and what to do if you're experiencing anxiety and some coping strategies. We felt this was a really important session to offer, as we know people are feeling really anxious at the moment about the current situation. We also run some virtual group sessions, such as Pilates, breathing workshop, yoga and some cookery workshops. And we've also recently started running one-to-one sessions for acupressure. Some of our partners across the area have also moved a lot of their services online as well, such as Look Good Feel Better, who used to come into the centre to run their group workshops. They have added resources and tutorials onto their website and have also started running live workshops. And all the information about their services can be found on their website. Also, Brighter Outlook, who used to come into the centre and run their exercise classes, are still providing support for people living with and beyond cancer. Again, they're still accepting new referrals, and you can self-refer through their website, either by filling in a form or emailing the team directly. They've started running weekly Zoom exercises, and during lockdown have run 39 sessions, of which 92 clients have participated in. They also have video tutorials on their YouTube page, including some seated sessions. Next slide, please. So this table quickly shows the number of supportive contacts we've had with clients throughout the month of May, using the different platforms that I just mentioned. Next slide, please. And I will quickly go through some of the services that Macmillan are offering nationwide. So their helpline is still open, and it's open 7 days a week, 8 till 8. And this offers important information and support. And it can range from anything around questions about diagnosis, treatment, finances, or anything to do with cancer. Recently as well, Macmillan have launched a new service, a phone buddy service. And this service matches someone with cancer with a volunteer who understands what they're going through. And then the volunteer can give them a weekly call. Volunteer buddies provide a listening ear and can provide information about other Macmillan services. Macmillan have also set up an online coronavirus hub on their website, and it's an up-to-date source of information for people living with cancer. It includes short films from cancer care consultants, podcasts, and answers to common questions about coronavirus. The Macmillan online community is still up and running and can be accessed through the website. And this is a space where thousands of people from across the globe can connect and give each other invaluable emotional and peer support. And finally, recently, Macmillan have launched their Forgotten Sea campaign. This has been brought about because throughout lockdown, Macmillan have been gaining insight into cancer services and are being told that people aren't getting the timely support they need, and some vital appointments are being postponed, cancelled or changed, as we heard earlier. There's also been a drop in the number of people who are being diagnosed, and there are some concerns that this might be a ticking time bomb for a surge in diagnosis when lockdown is lifted. The campaign was recently launched as a sentiment to try and raise awareness around these issues. And Macmillan are also pushing for clarity for people who are classed as extremely vulnerable and what happens now with them coming out of shielding, because there's still quite a bit of uncertainty and mixed messages around this. And that's the end of my slides.
Thank you so much for a rapid romp through the Macmillan resources. And I do recommend anyone who is a cancer patient or thinks they may have symptoms, go to their website because there's a lot of help there. Now, as I said, all our we've had lots of questions coming in while we've been on air. I'm going to throw some privilege here. Howard, who happens to be one of the directors of Healthwatch Brighton and Hove, has asked a question about what percentage of patients that are asked to come to an examination in a COVID safe place setting following the initial consultation. So I don't know if anyone knows what percentage of patients are presenting in a safe setting. Richard, do you have any idea on that? Do you have a feel?
Well, we are doing most of our follow-ups we are able to do by telephone. I'm maybe one or two patients of a list. That's about 10%. If the patient's concerned they have a lump or they're requesting examination for bringing to clinic, we have in the last few weeks asked all our new patients to come to clinic because we felt that was an important moment to establish a connection and do a baseline examination.
Okay. Elaine, who has a history of bowel and stomach cancer, had a colonoscopy and a polyp removed 5 years ago and was told to come in again. Was due to have another examination in January. She asked when colonoscopies and endoscopies are going to be resumed. Any update on that?
So I don't know the answer to that. I know that colonoscopy was one of the services that was struggling most before anyone had even heard of COVID, and it's doubly difficult now. And if there was one part of the hospital machinery that needed the most investment to help cope with a COVID surge, it's colonoscopy. But I'm afraid I don't have an answer to when it's going to get back up.
Okay, I'm keeping half an eye on the clock as well.
What I would say is that this has we've talked about what can we do differently and smarter and better, and what has COVID taught us. And Mathew may have a point to make on this, but I think it has meant that fit testing as an alternative to as part of our colon screening has had a real boost because of COVID, as a safer way to screen patients for colon disease.
Now, I think you covered this. David makes a point. He says in March we were told that a cancer hub would be organised at Sussex in Brighton for Sussex in Brighton, and rather than Haywards Heath, and we were told that private hospitals would also be roped in. I think you covered that in your presentation. Yeah,
I did. So the Montefiore Spire in Brighton is now essentially an NHS cancer surgical hospital.
Okay, and Denise has got some question, I guess, is on a lot of people's minds. She asked whether I could ask on her behalf if there is another spike in COVID in the winter months, as some people are suggesting. will the response and effect on cancer services be the same? Or may things be handled differently now we've got more knowledge? Have we learnt anything, guys? Who wants to handle that one? Sorry to put you in the firing line there, Richard.
Well, so I'll go first then. I think it will be similar, but not the same, because we are, our learning. I mean, I have been never have I been more impressed with the NHS's resilience and flexibility. The ability of colleagues to flex the way they work across every part of the hospital has been extraordinary. And it's been very difficult to learn a lot of this stuff. But now everyone's a dab hand on telephone consultations, video. We have pathways, we have red and green channels, we have infection control procedures, and everything is getting slicker and quicker. So if it does hit us hard again, the impact will be there, but it will be less acute than it has been this time.
Okay. Mathew, do you want to come back in on that, or from a GP?
Yes, I completely agree with Richard. I think we geared up to deal with the spike, and the spike flattened. So in primary care, we have stepped up the total triage, as we call it. So that's telephone calls and video consultations from 5% about 6 months ago to 98% today. So it won't be the same. We will cope with it better than it has been previously. Yeah.
Okay. Well, it's good to know we're in a learning environment now. Sarah Jane just harks back to one of your graphs, Richard, which graph about COVID risk, and she is asking: is it risk or diagnosed with risk with COVID? I'm not sure whether that's clear.
Yeah, those graphs were specifically about patients who had a proven diagnosis of COVID, and in a large number of patients, they were able to continue to their even despite having proven COVID, they were able to continue to their original cancer plan. I should say, if people are interested to see that data, it's published every Wednesday. And if you go to Google and type in UK Cancer COVID Monitoring Project, you can sign up and you can see that week's data in your inbox.
Okay. And Angela asks whether anyone on our panel knows whether there are regional variations in screening, testing and isolating. She tells us that she knows someone who was treated at ESHT during the lockdown who wasn't screened, tested or isolated. Any comment from anyone who might have an inside track on that one?
So we've had the testing guidance changes all the time. You have to be pretty quick. By the time you've read the 27-page document, a new one's out. But there is new guidance today. And the new guidance today in terms of our cancer patients is that testing policies should be determined locally based on the background prevalence of the virus. So if you have a large number of infected people in the locality, your testing policy is going to be different compared to an area where there's a very low background rate. But the principle, any patient who's coming for a long course of radiotherapy or chemotherapy or cancer surgery can expect to be tested prior to that treatment starting.
Yeah, and I see you've answered a question about the Montefiore and endoscopies in this chat line there. But anyone worrying about whether those are available at the Montefiore, they are, and they're doing colonoscopies as well. Is that correct, Richard?
Yes, they are. And the second follow-up question to that is, will a 14-day isolation be required? Anyone visiting a clean hub will be asked to isolate for 14 days beforehand, because the clean hubs only work if uninfected people come into them. So we have to do everything we can to keep them clean. So all patients will be asked to isolate for 14 days before entering a clean hub.
Okay, and I guess this is another endoscopy question from Janice, who's age 79. She was diagnosed with a low blood count in January and was on a fast track for investigations for possible gut cancer when the lockdown came in, and her endoscopy was postponed. And this may be an unanswerable question. How long will it be before the test will happen? She now has a lot of stomach pain.
Well, I don't know what Mathew thought, but I'll pass that back to Mathew, because I might ask her to go and back to talk to her GP again to be reassessed, because it might be that she needs her GP to advocate on her behalf for another pathway.
Yeah. Would you want to enlarge on that, Mathew?
Yes, I mean, I think there are two ways to bring this back to our attention. As I had said, the GP is one way to do it. However, the GP will already have made the referral, and the patient porogenesis is in the process of being investigated. The telephone number that she will have been given to call back should her symptoms worsen, and patients certainly are given those telephone numbers, should be used. Please don't worry about using that. If your symptoms are worsening, then use either that telephone number or contact your GP again.
Okay, another one that's coming in advance from Pat, and I'm sure she's 72. She has breast cancer, and she's on medication and been called in for a mammogram. She's been strictly socially isolating, and she's rather worried, like a lot of people will be, about picking up COVID. In a way, you've told us about the protocols in place, but she really would like some reassurance whether it is safe to go in and have that mammogram.
I mean, I'm absolutely sympathetic to that view. We know patients who have been, citizens who've been at home very carefully shielding and not going out and about, and then we invite them to leave their home and come into a healthcare establishment to be seen by a radiographer who's working with other radiographers and going back to their own. You know, I can see why it's a concern. We have done everything that we can to make those procedures as safe as possible. All staff are in PPE. Patients are invited to have are able to have PPE. If you come to the, for example, if you come to the mammographic screening unit at the Park Centre, you'll be screened for COVID symptoms before you arrive. You'll be offered PPE. All the staff that you see will be wearing PPE, and there is a clean down. Anyone who's had a mammogram will know it's an up close and personal physical test. All of that equipment is cleaned down afterwards. Nonetheless, if an individual felt that they did not wish to take that risk, they just contact us and we'll put them back on a rolling list to be called back at a later date.
This question really kind of speaks for a lot of people of a certain generation, and I include myself, where they don't want to bother their GP because they know that everyone's rushed off their feet. But John, who's 69, says he's been feeling sick and lost his appetite for the last couple of months. Lost a bit of weight, feeling tired, and he doesn't want to bother his GP as he knows how busy they are. And he'd heard that they weren't seeing patients. So this one really is for you, Mathew. Are GPs open now? Well, I don't think you've ever been actually closed, but I'll let you answer for that.
Yeah, thank you, Geoffrey. No, we didn't close. We simply transferred to trying to prioritise who we talk to and when and how. So no, please don't have that feeling at all. Everyone who has a concern about cancer needs to contact us. We are open, we will deal with it. It's just that we will use technology that we have not used before.
Okay, and I guess the same goes to Emma, who has a lump in her breast, which presented last year. She had a mammogram, which revealed it wasn't cancer, but she's now fretting because it's getting bigger. It's not hurting. Should I go to my doctor? So what would happen? So what's your advice there, Mathew?
Yes, I would say go to your doctor. We understand anxiety is high and justifiably so. If you are concerned, we are there, and your GP will know you, so he will know whether you're not the sort of person that normally worries, and you've come back, and therefore he will, and he knows that's a red flag to him. So please don't worry about any of that. And we're doing the first contact over the telephone, so you can talk this through with him before he actually brings you in. But no, all my colleagues would not have any problem if you phoned up and said, look, I am concerned.
Yeah, and there's another, actually this is coming from a member of staff, the COVID-19 Community Connector. So that person has been recently informed that by a member of the public following surgery for breast cancer, that they were told that all normal follow-up appointments were now not happening, and that next time they would be seen would be following a mammogram in 12 months' time. They are understandably concerned by this, given the referrals of cancer had been at an all-time low during the pandemic and are still not back to normal levels. Why would this be? Surely patients will need to have more assurance during this time than normal, not less. I guess you can't disagree with that.
Well, it's interesting. One of the interesting things about I remember working for someone who told me that doctors never change. All that doctors do is they die or retire, and then they're replaced by new doctors who then change. That's the only way we get change in the health service. I don't know if that's true, but one of the things that we've been trying to change around breast cancer follow-up is moving to what's called managed self-care, knowing that actually a hospital visit for a woman who is well informed and has a phone number that she can ring and expect an answer is just as good as being seen regularly in hospital. Now, not everyone was willing to engage in that. That's something we've been doing in Brighton for a long time, but actually COVID has enabled that change to happen system-wide quite quickly. So it has enabled some change that we've been wanting to make for some time. It's just important that we support it with the information that patients need to manage their care appropriately.
I'm conscious of time ticking on because we've got 3 minutes left, but I mean, there's an interesting question which you, in fact, some of your presentations indicate that things will never go back to exactly as they were before because you've become leaner and more flexible in your working. Morris, who's 47, says COVID-19 have made many changes to the way cancer services have been delivered, and that's been reflected in your presentations. To what extent are these changes likely to stay permanent after COVID lockdown? Do you think that some of these practices that you've adopted, which allow you to use technology rather than face-to-face consultation, will actually carry on?
Well, it was, I suddenly realised that people didn't necessarily want to spend an hour driving to Brighton, finding parking and sitting in for 45 minutes in my waiting room just to talk to me for 5 minutes when they could have done it on the telephone. That was a light bulb moment for me. And of course, actually, the adoption of telephone and video has been something we'll definitely hold on to. And I would like to see a future where we offer patients follow-up, and then we give them a choice when it comes round to their appointment. We just say, would you like that to be a telehealth follow-up, or would you like it to be in person? And we can flex the system accordingly. And I think that would be huge. We know that coming to hospital is incredibly disruptive for patients. They have to take time off from work, they have to arrange childcare, they've got to pay for parking, and if they can do it all over a telephone in the comfort of their own home, well, all the better. I've also noticed that when people are at home, when I do a teleconsultation, they ask me more difficult questions. I think being in their own environment, makes them more comfortable. So maybe that's a good thing too.
Okay, well, listen, we're almost at the end of our allotted hour. How time flies when you're enjoying yourself. We have lots of questions that still have not had specific answers. We will try and get all those questions answered and out to everyone who's posed them. There will be in my thanks go to Michelle Kay, who's been working her socks off in her I don't know where she's working from her dedicated office in her home, but she and some others are putting together a summary of this. The presentation will be available on our websites, and the fact sheets that I refer to will be published also there. So thank you everyone for tuning in. Watch out for the follow-up and the feedback. Thank you.